Welcome to World Pediatrics, Healing Beyond Borders, the official podcast of World Pediatrics. I'm Reese Williams, and I'm so excited to invite you into this space where stories of hope, healing, and transformation take center stage. Thank you for joining us for another episode of World Pediatrics podcast, Healing Beyond Borders. I'm Reese Williams. This is our fourth episode, and today we get to talk about capacity building in the context of pediatrics. My guests today are Ross and Harper. Hello.
Hi.
And since you're closest, I'll start with you. Expand on capacity building in the context of pediatrics. What does that phrase mean in your world?
For sure. When we talk about capacity building, we're talking about strengthening and developing local resources in the countries and regions and areas where we work.
And that is, we've talked about this on prior episodes. When you go into an area, you're there for care. It's not just addressing, you're not myopic, you're not just addressing the one thing and leaving. You are teaching them to fish, so to speak, and you're trying to expand on what you're doing there. Is that the context?
Yeah, certainly. I think that's a pretty good summary of it. When we look at it, there are certainly kids who need treatment today. The capacity building components of our programs are looking at those kids for the future, and how do we create sustainable programs within sustainable health systems that can treat more kids in the future.
And that was always exciting on prior episodes, talking to physicians and facilitators who had helped babies and infants, and then they got to meet them as adults and see them grow and see their communities improve and thrive. So that's a really interesting facet.
Yeah, it's super cool when you start to see the kids, get older, and then they're working at the hospitals as nurses or docs, and they're coming back and working with the teams. It's kind of a full circle moment there.
Very rewarding. Mm-hmm. And where would you say, Harper, the gaps are? What do you find you have to strengthen most when you're in areas for the capacity building?
Yeah, so I'm going to speak specifically to neonatal care. And within neonatal care right now, worldwide, the care of small and sick newborns is really the biggest gap and the top priority, again, within that category. So that's taking care of premature babies that are born with some kind of illness. Actually, the leading cause of death for children under 5 is prematurity. And within neonatal deaths, prematurity accounts for 45% of deaths. So it's a really big problem worldwide. We've seen a lot of progress in the last 20 years in terms of child mortality and infant mortality. But when it comes to infant mortality, in a lot of areas, we've kind of reached that low-hanging fruit, if you will, and now we need to go a little bit higher level and into the more impactful interventions.
We've just gotten started, and something that I noticed the last episode is just how much what World Pediatrics does should make us appreciate what we can do in this country. I think so often our healthcare system isn't perfect, obviously, but the fact that we have access to what we have access to and the level of professionalism that we have and that those mortality issues aren't as prevalent here is something to be very grateful for. So I love that you guys bring that little clarity for us. Ross, what makes an area ready for that? I mean, I'm sure you go into areas where even if you wanted to teach them to fish, so to speak, they just couldn't. And I don't know if that's geography, facility, but what makes an area ready for you to say, we can put a plan in place?
Certainly. When we look at different, emerging opportunities and we start to evaluate the potential within, different areas, we're looking at the gaps in the systems that we can help bridge, right? And so this is going to look very different, as you said, based on geography, based on population sizes, based on access to resources. We're evaluating the full spectrum of kind of the health system and the population that it's trying to reach. Urban populations, of course, look very different than rural populations, right? So when we were working in the Caribbean islands, for example, solutions that we look at for populations of 92,000 on average that are geographically isolated are going to look very different than when excuse me, we're working in a country like Honduras or Guatemala where you have 10 million or 17, 18 million people, right? And so their access to resources, their access to communication, it looks very different than the geographically small populations that are isolated like that. So we evaluate that full spectrum. We look at different delays along that spectrum. So we look at, there's going to be delays seeking care for the kids and their parents. There's going to be delays reaching care. And then even if you get there, there's still going to be delays receiving the care. So our programs really look at those three delays kind of along that continuum, if you will, and try to figure out how we can bridge gaps along that way so kids have better access.
Have you ever encountered a situation, I know we have cultural differences around the world, has there ever been a cultural difference that you had to be mindful of or respectful of to move forward? Or in the medicine world, I don't want to say it's a level playing field, but do people know these things just have to happen to do what you need to do?
Sure. I mean, all the time. We're working in various different cultures. I mean, from the Caribbean to Latin America, that can look very different. Even, I guess I can recall one example. This year we worked with, or last year in 2024, we worked with the traditional midwives in the Mayan communities of Guatemala. And so there's a huge, I think the biggest in the world, Mayan population within Guatemala. And many women choose to give birth at home rather than in a health facility because for thousands of years, that's the way that they've done it. And so they're called comadronas in Spanish. And the traditional midwives go into the home, accompany the woman throughout her pregnancy and then during the birth. And that can look very different from giving birth in a healthcare facility.
Wow.
For sure.
Yeah, and I would piggyback that just by saying, within the organization, we have local staff employed throughout the different regions and areas where we work. And so a lot of stress and emphasis within the organization as a whole is put on that cultural competency and building it from a grassroots level in terms of what's needed and how we evaluate these programs and then building the structures to those bridges.
I'm glad that Ross said that because for this particular program, we hired a local pediatrician who's a public health expert with more than 30 years of experience to lead the program. And then she, in turn, because she herself is Guatemalan but not of Mayan descent, she worked alongside kind of the leader of that region because there are also many different languages within the Mayan community. So you really have to find those local champions who are going to understand the local context and be able to work even within those microcosms of cultural differences.
It's just another way that World Pediatrics goes above and beyond. It's fascinating every time I chat with someone to learn more and more about how involved that the organization gets. So speaking of that, when you go into a particular area, you've decided that it's a great fit for capacity building. Who on the team gets together to ensure that? What levels of people in World Pediatrics get together? How do you strategize that? How long does that take to make sure that happens instead of just sort of a in and out?
Right. I would say, to answer initially, everything we're doing is locally led and locally driven. So so we evaluate the opportunities, but those opportunities have come to us. We're very much about being pulled into an opportunity, into a situation, rather than pushing ourselves onto another region, country, hospital, whatever that may be. And so the first level of that evaluation is happening within the system. It's happening within the country, within the system, within the healthcare professionals and the healthcare administrators. And they're coming to us and identifying, what that gap is. We help, in the conversation, the dialogue, to understand possible solutions that can be implemented at a local level through a local context that will then become part of that overall kind of healthcare system that will then generate a sustainable kind of return in the future.
It's already a warm introduction.
Yes.
Would you say the same? Would you agree?
Yes. So it's definitely an interprofessional kind of process. So Ross and I are there kind of as the staff members with the experience. I think he's been with the organization for almost 10 years. I've been there almost 12. So we have a breadth of experience and maybe access to, this is our daily bread. This is what we do day in and day out. So I kind of know what has worked in other settings and maybe what hasn't worked as well in others, and Ross as well. So it's kind of taking that knowledge and then combining it with the medical knowledge that the medical professionals are going to bring as well in their expertise, so that we can come up with a solution that's going to take that public health perspective and be sustainable from at an administrative level, but then also utilize the skill sets of the volunteers.
This is what we talked about last week too, is advancement within the program, or if you're already a part of World Pediatrics, just assisting people in different positions because you've worked in the different areas. You can, if you do move on to the admin or, in these other capacities, that you have that background knowledge to inform those decisions. I think that's really important. Neonatal specifically, how can we best train workers to be able to give that care for a long time, specifically in neonatal?
Yeah, that's a great question. And it really starts with going and teaching what the science tells us to teach, so interventions that are based in evidence. Because the world decided to develop these sustainable development goals, there was a lot of research put into, what actually works in terms of teaching healthcare workers and having a sustainable change in terms of training and implementation of some of these interventions. So some of the programs that we work, for example, that are based in evidence are WHO's program Helping Babies Breathe, Essential Newborn Care, care for sick and small babies. And all of those programs are based around small group settings and simulation-based training. So for the layperson, if you've ever been to a CPR class, you use a adult mannequin at one point during the class.
Is she still Annie? Is Annie okay?
Yeah, yes. I believe it's still Annie.
Okay.
And so, you use that mannequin, and what we call them in neonatal is neonatalies. So we have neonatally mannequins. They're little baby mannequins. They range from ones from the WHO that you fill up with water and can be used in any setting, in any kind of clinic, to teach neonatal resuscitation, all the way to, very fancy ones that do all kinds of things and have like a heartbeat and everything. But typically with Helping Babies Breathe, we use these neonatalies to teach proper resuscitation technique. The three leading causes of death that we kind of already talked about within neonatal is sepsis, prematurity, which we talked on, and then neonatal asphyxia. So that's when a baby is born not breathing. And 1 in 10 babies are born not breathing or need assistance to breathe. Sometimes that means that you're just rubbing the baby, stimulating the baby, but sometimes that baby's going to require what we call a bag and mask to help the baby to breathe. And learning that technique takes a certain level of skill and practice. So you need to practice doing it because it's not something that you're going to do every day, especially if you're in a rural clinic setting. So that's just one way that you kind of take these interventions that have evidence that work, and then start with that.
And how do you know, I guess it would depend on how often you go to these specific sites, but how will you know that it's working? What's the measure of success that we've implemented this program and it's flourishing, it's driving forward?
Yeah, that's always the golden question. At a macro level, and the pie in the sky dream is that you're going to see your neonatal mortality rate, and that's a fancy way of saying the number of babies that are dying, go down. And that takes the other thing with the approach to a neonatal program, it has to be holistic. So we can't only do one thing and then, expect maybe we will be able to resuscitate a few more babies than before if we do Helping Babies Breathe. But then what if we resuscitate the baby is still sick, and now we need to get the baby to the hospital. So now transportation comes in. And then once the baby reaches the hospital, is there a trained personnel there to receive the baby and continue to work on the baby? So in this program, it really has to be a whole systems level intervention to really see a drop in mortality. And that means bringing a lot of different stakeholders together over a long period of time. The other thing that has to exist really to see at that macro level a big drop would be the political willpower. So politicians and government have to kind of decide, okay, this is a priority for us. Too many babies in our country are dying, and we're going to put in place the policies to kind of, and it doesn't always even have to be money. I mean, there are some things that you can do. At the end of the day, it will eventually come back to money, but there are some things that you can do, to retain your staff and other things that will have impact on your mortality rate.
Well, speaking of the long-term progress and employee retention, Ross, how does World Pediatrics make the medical professionals feel empowered and feel like they've collaborated with World Pediatrics, now they can move on, they've got the confidence, they know they can reach out? I mean, every time I talk to someone from the organization, I hear about another facet that's thought about and looked at, and it's just incredible how thorough. So how would you say that care for the medical employees moves forward as well?
Certainly. So these programs are not one and done type programs, right? So these programs are long-term programs that are developed, with long-term goals for the capacity building and that strengthening of skills and development there. So the communication is ongoing. This is not just the medical volunteers are only there for a week in front of a local physician or a local specialist and training for 1 week, and then they disappear for the next 51 weeks. These programs have constant communication. They're constantly bouncing ideas off one another, sharing knowledge, and the kind of that skills transfer that's happening there. It's year-round with the physicians and then with the medical professionals in the region and in the country. The other key component to it, too, is historically a lot of the programs, the same medical volunteers have gone to the same place, worked with the same individuals at the same time of year, over the course of 10, 12, 15, and for some 20 plus years. And so when you start doing that, the relationships start to get built and developed. And so that happens within the hospital systems, that happens on a personal level between colleagues and physicians, that happens with support staff, that happens with parents and patients within the community. They see the medical volunteers as a partner in kind of the children's care.
Someone who's an established part of their community now.
Yeah, in a lot of cases. Yes, absolutely.
It's a lot of building trust over time and even starting the conversation so that even colleagues within the same region can be talking to each other in a way that maybe they didn't have an opportunity before. For example, the islands that we work in the East Caribbean, geographically isolated, they might not always have a chance to get together. So I did want to mention that we just recently completed the second perinatal health conference in Barbados for all of the neonatal professionals in the region. And if anything, it's just a great thing to do because it brings all of these professionals together in one room to talk about, okay, we had great success with this intervention, we're struggling here, and then they feel like they can, pick up the phone and call this colleague that they met at the conference and say, hey, I have this baby, I heard you're doing this really well, what can I do, here in my setting?
This is so exciting to be able to share this message with people. I can't wait for so many more people to know that this is happening. And
we're excited for you to share the message with people.
It's great. Right. We talked a little bit about, of course, every area being different in terms of what you can offer based on geography and their capabilities. What does make an area easily conducive to be able to help as best you can?
I mean, first understanding this is a global problem, right? So we're talking, at this point, rough estimates somewhere between 1.8 billion to 2 billion children lack access to safe and affordable surgical and anesthesia care. So this is global. This is not just in a specific region or a specific country. So with that understanding, when we look at our programs and our program structure and where we have our competencies, as an organization and our core skills, if you will, as the organization, it's working with partners who want to develop specific components within their system that they can then look at as being sustainable for the future. So that's what we look at within these programs, is we look at the holistic structure of that health system, and if there are specific points that we can bridge those gaps, then we can start to strategize around that.
Do they ever reach out for that strengthening in general, or does it always start with a specific case?
Oh, it can be both.
Okay.
Okay. We do have a lot of specific cases that are very unique, but then also they can also be looking at it in terms of their overall kind of advanced pediatric care health system and the structure that they have, and how can you make structural changes or adjustments within that system.
And what's a great wow success ideal story that you have where somebody reached out, they were poised to develop well with the collaboration? And
do you want to talk about scoliosis?
Sure. So I wasn't going to, but I will.
No, go. You should.
Don't be shy.
It's a good success story.
Well, I appreciate the push.
There you go.
Just fun. So
are you going to brag about yourself or else? No.
No. So we started doing scoliosis surgeries, orthopedic spine, scoliosis correction type surgeries in the Caribbean back in like 2008, 2009. Complicated surgeries, that are pretty intensive for the kids, but also very needed. And so we were sending medical teams, we were doing it, but we also knew we weren't making kind of great inroads on the backlog, with that. And so in 2015, we started decentralizing that surgical service and regionalizing the diagnostic services. So we started sending out regional diagnostic teams to the different countries to host clinics and try to get a better understanding of what that overall number looked like. So ballpark figures, 1 in 1,000 people born need some type of surgical intervention for orthopedic spine scoliosis type cases. And so we knew the incident rate numbers, but we also knew we were not seeing the right number of kids based on those incident rates in the clinics. And so we adjusted our structure a little bit within the region, and we started trying to identify those kids. And so after a couple of years of going to the different islands, hosting the clinics, we had built up kind of a patient volume, and we were able to approach some companies who work within orthopedic spine surgeries, and we're able to garner the support. And since 2017, we've been sending multiple teams and helping a lot of children with the orthopedic spine. And so it was we changed our structure to our programming, and we're able to adapt and then be able to reach more kids in less time.
Smart.
So,
Very smart.
Yeah.
And Harper, I'm sure there are, I shouldn't say are there, what upcoming strategies are in the works for really strengthening that capacity building with World Pediatrics?
I think we're just looking at what we can really take to scale in terms of which interventions, how do you package it, how do you have that. We know how to have that introductory conversation, but kind of like what are the steps, and just putting this together in a entire package so that you can really go in and being able to, because it's complicated. It's a complicated approach, but to be succinctly say, okay, with this much funding, we can bring in this many resources, and again, really try to holistically kind of take an approach to either whether it's going to be a hospital system or primary health system or both, which we work in all levels of the healthcare system within this program. So I think in the future, it'll just be kind of, again, deciding which pieces of the puzzle, we'll be able to take at scale.
I would also suggest one other thing I think we're doing a little different now than we had done in the past as we're adapting is tapping the regional networks that exist and the regional and local skills that exist within the places where we work. And even when we're exploring new opportunities, we're looking at those regional networks and seeing if there are pathways to creating kind of regional collaborations within the pediatric advanced specialties to create training programs. Yeah, no, we have one in Vietnam right now, which we just launched, and it's a collaboration with a surgeon from Taiwan and a surgeon from Vietnam, and building up the capacity for pediatric general surgery and laparoscopic technique at a hospital in Vietnam. And so it's a regional collaboration.
Yeah. I think that brings me back to something I wanted to mention at the beginning, which is that we work with some incredible healthcare professionals, in the field abroad. Oftentimes, there are people that have very advanced training. Some of them may have gone elsewhere to do their training at university hospitals and then decided to come back to their country or stay in their country. And that is a conscious decision that they are often making, to say, I want to stay here and really improve things where I am in this hospital and improve things, in my community and in my country. So just many kudos to the champions that we work with, because it really has been kind of a, in some cases, we're always going to continue to rely on teams to bring in some of the expertise and treat a lot of kids at once. But in other situations, we are going to be able to rely on local professionals and just giving them the resources that they need, especially when it comes to things like neonatal capacity building, to really be those champions to make the difference within the hospital that they're working in every day.
What do you hope neonatal care looks like in the next 5 years to a decade? What's your hope, your vision?
Yeah, I mean, let's see. I hope that we continue to get lots of funding because this is an underfunded area worldwide. I hope that we continue to work on family-centered care, so empowering families throughout the world to be involved in their child's care to the maximum extent possible, especially when we're looking at NICUs. In many places across the world, families are still kind of separated, so they can only go into a neonatal unit for an hour a day or something like that. So we really want to see more opening of units so that the parents can play an active role in their child's recovery, even within the NICU. And then I do think this is kind of a standard answer, but there are a lot of technologies out there that are going to potentially transform the way that we take care of neonates, especially with the use of AI, which can help to. We're already using some ultrasound that have AI technology, some companies that are making the decision to build global health into their strategy. So not only deploying these things in the U.S., but then doing it across the world in high-need areas. Butterfly is one of those companies, an ultrasound company that has decided to do that. And their device can help the clinician pick up on certain disorders within, internally. So faster diagnosis, I think, will be great and save a lot of lives as well.
And Ross, what are some plans for global expansion for World Pediatrics? World domination.
I was going to say, you make it sound like we're the empire here.
No, just expanding that care, casting the net wider.
Yes. So, we're certainly always exploring new opportunities, new ways to reach more children in less time. This is a global problem, and there is no shortage of need in terms of lack of access here. So definitely, as Harper mentioned, there's a shortage of funding for this. And it's expensive. Advanced pediatric care and services, especially at this tertiary level, is expensive. And the organization has made a conscious decision to not just focus on those particular conditions that are maybe more affordable to treat and you can generate higher numbers with. Nothing wrong with other organizations that have, I'm not suggesting that. It's just a decision by the organization to treat the most complex cases. Right now, we have some very complex cases here that are at our partner hospitals in the United States that they're working through that can only be treated at a couple facilities here. And then the teams and the way they stage these surgeries and the doctors, this is very complex care, which is expensive. Mm-hmm. And so funding becomes a component to it, when we start to look at opportunities and what we're able to do.
It's critical.
Mm-hmm.
Harper, what are other ways, obviously monetarily, but how can the throngs of people watching and listening contribute to better worldwide healthcare that World Pediatrics is doing?
That's a tough question outside of funding.
Hugs.
Spread peace and love. Yeah, I don't really know how to answer that outside of, that's the desperate need, especially as we see some of the political strategies here in the U.S. changing and things like that, is really going to be funding and understanding how some of these things help. They impact at a community level, but I guess saying that butterfly effect that goes out to having stable communities and the impact on a family if their child lives and then contributes to society. So I think just kind of having that awareness and the understanding of the why and how, we talk about this a lot, how it will benefit patients here in the U.S. as well. If your doctor has traveled and treated conditions that they will never see here in the U.S. because we treat them early on, but instead you see, pathologies that have been allowed to go years and years and years, that's making your doctor a better doctor. That's making your surgeon a better surgeon. Learning to do more with less. These are all, great lessons that they can bring back with them.
And hopefully additional compassion, too.
Yeah.
I think it's really important when you seek healthcare and you can tell that they're legitimately interested and that they take the time to listen and they do have that broad background of so many different cases. I think is incredibly valuable.
Yeah. And for folks here, I think, too, it's just the public awareness and the understanding that, in terms of humanity, that there are a lot of people who need this access and this type of help that, for the most part, is available, as you had alluded to earlier, is available in their backyard. But it's not available to most of the world. And so, having that understanding and what Harper had just mentioned, that butterfly effect, if you will, but these surgeries are about doing one surgery on one child, but that surgery can change the impact for that family if the parent doesn't have to stay home. So there can be an economic impact with that, but there can also be the social impact in terms of the happiness of the family. That family has an impact within the community. That community has an impact within the overall country, especially in some of the small island states. And you start to see how this impact rolls up. And that child that has received the surgery is no longer kind of a net negative on society because they are draining resources. They become a net positive for this society. So when you start to look at that as one case, and then you start to consider 25,000 kids that have been treated over the years with this organization and what that net impact that's rolling up is, for these countries, but also just for humanity and for societies. It's very important.
It's a big silver lining.
Mm-hmm.
Very big silver lining. Thank you for joining us today. We really appreciate it. Yeah. Thank you very much, Harper, Ross. Thank you.
Yeah. Well, thanks for having us.
Absolutely.
Yeah.
Thank you for tuning in once again. If you haven't already, please go watch episodes 1 through 4. This has been Healing Beyond Borders, the World Pediatrics podcast. I'm Reese Williams, and we'll see you next time.